So thank you for joining us. I want very much like to introduce you to our guest speaker today, Timmy Schrumpf, who, as soon as she started talking, I said, oh, you need to tell my members all this. And so I know enough to know that what they offer is coming from a really cool model, and it's coming from a nonprofit perspective, and it's been growing organically, and there are opportunities to really help you all expand the tremendous work that you're doing. So I'm just going to hush and turn it on over to Timmy.
Thank you. Thank you very much, Mary. I'm glad to meet all of you this morning, this afternoon, depending on where you are. I'm Timmy Schrumpf. I'm the Director of Telehealth Partnerships for the MAVEN project. Trying to advance my slide. Give me a second. As Mary mentioned, the MAVEN project is a 501c3 nonprofit supporting primary care providers in underserved communities by linking them to experienced physician specialists across 53 clinical specialties via telehealth. To give you a little more information about the specific opportunity, we recently received a grant from Gilead Sciences to bring our services to up to 5 clinics in areas that are severely impacted by HIV and AIDS. When doing some research on these communities, Memphis, Tennessee was on the list due to actual number of cases. However, we recognize that map borders aren't just clearly defined. There are other areas in Tennessee that are impacted, whether because they're serving large communities of color, which, as we know, are disproportionately affected by HIV and have poor health outcomes. So I reached out to Mary at TCCN, and here we are today. And just so you know, the chat box should be opened, and Sarah can field questions, and there'll be time for questions and discussion at the end, but I am very informal. So as I'm going through these slides, please feel free to unmute yourself and ask questions and make comments, so we can just have a more organic discussion.
Okay, can I start with a question before you jump in?
Of course.
Which is it also a service that, like TCCN could try to get a grant for for those communities that want this service, but don't have the statistics or, the incidents that you're looking for this particular grant opportunity? It is something that you provide to others as well, right?
Absolutely, 100%.
Talk about that.
And I think that's a great point, Mary. I look at this grant opportunity as a way to as a catalyst for what should be and hopefully will be an ongoing partnership.
Great. Okay, I'm quiet again.
So this just gives you a sense of where we are currently partnered. This blue states represent states we are currently engaged in, and we will soon be turning Tennessee blue. And this is a sampling of our partners across our network. We're currently engaged with 137 free and charitable clinics, FQHCs, and down here you can see the organizations we're partnered with, national organizations such as Direct Relief, health plans, and other state charitable care networks. And most importantly, what we can do for your providers. So as I mentioned, the MAVEN project supports primary care providers who are caring for underserved and uninsured patient populations. We define primary care providers as physicians or advanced practice providers, so MDs, DOs, NPs, and PAs can all use our services. We have 3 core service offerings. Our primary service are medical consults. We offer these both in asynchronous fashion, e-consults, the email-like communication. A provider can log on to our telehealth platform, fire off their case question to a specialist, and get a response, or recognizing, however, that some cases aren't so cut and dry and they could profit more from a live conversation like we're having now. A provider can log onto our platform and schedule a time to have a face-to-face conversation with a specialist in real time. And we also offer some limited on-demand phone consults in cardiology and hematology. Right now, we have over 135 volunteer specialists in 53 specialties, and this is continually growing. And right here, we just outlined some common uses for medical consults. And as cliche as it sounds, something that our volunteers always ask me to convey is that no question is too small. Even if you don't know where to get started on your case, or you just want reinforcement in your decision-making, they are there to help for both the simple and the complex questions. I'm going to pause there. That was a mouthful. Any questions, comments? Moving on. And our platform is designed to be very easy for providers to access. You just simply log on to our homepage at mavenproject.org, click telehealth login, and you enter your unique login credentials and you're brought to our homepage where you can click on the desired specialty and send your consult. And this slide just demonstrates the breadth of specialties that we have available. As I mentioned, we're at 53 and continually growing, and you can see we have everything from pediatrics to geriatrics and a wide variety of subspecialties. And moving on to our second service line, educational sessions. We currently have a catalog of over 200 available sessions, everything from the ABCs of EKGs, PCOS in adolescents, and also more provider development, professional development focused talks, such as how to engage with difficult patients, the 4-habit model of communication. We offer a minimum of 8 sessions per month, all of which have CME attached through our partnership with UCLA. And we can also do customized sessions on request for your clinic. So say your clinic has a standing provider meeting the second Tuesday of every month, and you just have a need, something focused on neurology, let's say, we can absolutely bring in one of our neurologists via Zoom and have them give a didactic for your provider group based on your needs, and CME will be attached with that. However, recognizing that providers are often busy with patient care during the day and they can't make time to attend live sessions, we record all of our sessions and post them on our website for anybody in our partner network to be able to log on and access on their own time. Again, giving a little pause for questions.
Timmy, is that if for those that aren't going to get the 5 free grants, which is definitely what's on the table here, but is that included or is that extra?
So as a MAVEN partner, all of our services are included.
Thank you.
Yes, unlimited access to our services. Great question. And moving on to our last and arguably probably our most impactful way we support providers is through mentoring. We have both clinical and leadership mentoring for new or seasoned providers. Interested mentees complete a very brief baseline survey where they indicate when they're available for sessions, what their goals are for mentoring, their clinical background, so on and so forth. And my team very intentionally and thoughtfully matches them to the most appropriate mentor to hold these mentoring sessions, where they can cover anything from career goals, professional development, combating compassion fatigue, and you can also cover clinical cases in your mentoring session. So it's a consult mentoring hybrid, if you will. So those are our 3 services we offer all of our partners. And this slide overviews some of the impact that our programs are having. So you can see here that 85% of consults results in saving an external referral to an in-person specialist, which, as you all know, when you're working with underserved and uninsured folks, this is a huge. And 90% of our consults provide education, which can be applied to future patients. And here you can see that we're just bragging a little bit. Clinic providers love us. Our average experience with our volunteers is sitting at an almost perfect 4.9 out of 5. And the average e-consult turnaround time is right now sitting at about 8 hours. So there's a chance when you fire off your e-consult in the morning, there's a high likelihood that you'll have a response in your inbox by the time you leave clinic that day. Here's some success stories you all can read, so I won't read these all to you. This outlines some of the positive impact we've had on our clinic partners over the past year. These slides will be sent out after this session, so feel free to review this. And next, as Mary mentioned a second ago, what does partnering with MAVEN bring? You have unlimited access to all of our services, our consults, educational sessions with CME, the customized sessions, the recording, clinical and leadership mentoring. Also, as a clinic partner, you'll have a designated partnership manager that will work with your clinic group for implementation at the beginning and ongoing support throughout the duration of our partnership. We also provide your leadership team with monthly utilization reports and data. Oh, looks like someone else is joining us. I will, Sarah, would you mind muting everyone, please? Thank you. And lastly, access to development staff to assist with securing ongoing funding. As we mentioned, this would be initially a one-year grant funded opportunity, but we are very confident that you would want to continue your partnership. And at that point, we can link you up with our development team to help you secure that ongoing funding for additional years of partnership. And lastly, what makes a good partner? Next steps. The fact that all of you are on this call and in the TCCN network, you're already a great candidate serving the underserved and uninsured. Also, it's very helpful since we are a telehealth organization if your providers have access to workstations and internet. And arguably the most important, just commitment and willingness, especially from leadership, to take on new initiatives. And the next steps, we're trying to make this as simple as possible, recognizing that time is not plentiful. This is a link to a brief application form that we will ask if you're interested for you to complete by next Wednesday, June 9th. And I do want to put out a disclaimer. If you don't have all of the information the form asks for, especially regarding patient demographics, completely fine, just do your best. Mary and I will let selected clinics know that they are selected by the end of Friday, June 18th. And we're planning on launching by July 1. So as you can see, this is semi-time sensitive, but we have designed the process to be very straightforward and simple, so there shouldn't be any barriers or red tape.
And so again, this particular application is for those communities that serve a population that has a high burden of HIV or what other, is it just HIV?
HIV/AIDS, yes.
HIV/AIDS. Okay.
And I do want to mention this was specifically written into the grant that even if, say, your clinic doesn't have a high number of patients with HIV, the fact that you're in maybe an area serving people with poor health outcomes, communities of color, does make you a candidate for this grant as well.
Great. Okay. So people, do you want to unmute yourselves and ask questions? One of the questions I have is just from my understanding, how much would it be if somebody were to want to buy this service to augment their care?
Yeah, absolutely. That would be for free and charitable clinics. The annual cost would be $6,750.
And for FQs, we have some of our FQs are partners of ours. We have Cherokee Health, which is just an amazing health system, FQ, and I know they're interested.
Yes, and for FQHCs, it's $9,000.
Okay. Okay.
Hey,
and
this is, sorry.
Hey, Brenda, hang on one sec. I just want to ask,
Sure.
Your development staff, are they interested in working with me to get a grant to support my network?
I can definitely introduce you to him. We can see, yes.
Okay, cool.
Yeah.
Go ahead, Brenda. Dr. Khatri.
Oh, no. Hey, thank you. And thanks for your kind words. Yeah, we've been very interested in the MAVEN project because we do certainly struggle with support for our patients who are uninsured. When with this, I just want to clarify, even so, if we apply, it is kind of the primary intention is to help support access to care for people for HIV, prevention and, treatment, but also looks like you have a much broader group of specialists. And so that, I just want to confirm that would be part of our partnership for this 1 year.
Absolutely. You would have access to all of those 53 specialties that I overviewed earlier.
Okay. And then, so then after that, you're saying it's 9,000. Is it 9,000 for the organization or 9,000 per site or provider?
Great question. So the base price for an FQHC is $9,000. If there are additional sites, that would be $1,000 per additional site. Regarding providers, that's completely unlimited. Recognizing that turnover, unfortunately, is a problem, and safety net clinics, if you hire 15 new providers throughout the course of the year, those folks can come on and have unlimited access to everything as well.
Okay. Sometimes like we have sites that have like one one nurse practitioner way in the mountains, and so the volume isn't as high. So I
Yeah.
didn't know if we can talk later.
Yeah,
and
and
we
to your point, Dr. Khatri, absolutely. We understand that if it's like in a school-based clinic, like one
right.
NP who's there like 5 hours a week, they don't need to pay that full $1,000 per additional site. So we're very flexible in that regard, but we can absolutely, Mary, if you wouldn't mind connecting Dr. Khatri and I offline, that would be awesome.
Absolutely.
Great. Thank you.
And
That's
everybody
very
can see your
exciting.
slides, right? Because your contact information is right here. Do you see them, Perinda? Can you see her slides okay? Oh, she's on mute again. Okay.
Sorry. Yes, and I would love a copy of the slides to show folks on
We'll
our
make
team.
sure you
So
get
this
that.
is very exciting. Thank you. And I will send you an email.
Thank you. And
Jenny was next. She had her hand up. It was so polite.
Jenny's so
Jenny
polite.
Bartlett Prescott from Church Health.
Hi there. This is a little bit along the lines of just volume or number of providers, but is there any limit on volume of consults requested? I mean, some of Church Health is a fairly large clinic compared to most of the TCCN clinics. And so, you know, we do quite a bit of subspecialty needs.
Not at all. We have across our network, we have partner clinics that are teeny tiny mobile vans that only see patients one Saturday a month, all the way up to really big multi-site FQHCs with 100 plus PCPs.
And then just as a follow-up, so is the limitation as far as the scope of this service providing a consultation for the primary care doctor?
Yes, we are not direct to patient, all provider to provider, which is why that we do have that limitation, either physicians or advanced practice providers to consult with the specialist.
Okay.
So that raises another question for me. I'd love some of our project access team to jump into the conversation. We're very fortunate in Tennessee that we have 5 project access entities, and their role is to secure and provide free and charitable specialty services. So I'm going to hush, and Ray, Bond, and Brooks and Clint are each represent 3 of the 5 that we're blessed with about how this could interdigitate. So Ray, were you going to speak, my dear?
Sure.
Thank you.
Yeah. Yeah, we coordinate in Hamilton County, and we're getting ready to expand into Bradley County. We coordinate a specialty care network and hospital services. So we've got a wide spectrum of specialists available. We get referrals. We strictly serve uninsured patients. We get referrals from 14 different primary care programs, and they refer them. And we've not done very much. We've not done very much with telehealth, but we try to serve as a conduit for this, or for our primary care clinics. We do some kind of clinic programs where we'll pre-screen, for instance, people for orthopedic referrals. So if they really need to be referred to to physical therapy and don't really need a surgeon, we aren't using a surgery appointment for somebody. So we do different kinds of patient screening to be sure we're directing them to the most appropriate specialist. But this is sort of intriguing. But I just need to think about it because it's a very different kind of model. But
Yeah.
I could see lots of efficacy. And part of what we also try to do is provide guidelines. So if somebody wants to refer a patient to urology, before we get the referral, they're asked to do specific kinds of tests for specific problems. So we try to do primary care provider education as part of that process of getting people connected to specialty care. So I just need to cogitate on it, but this sounds really fascinating.
And no, that's awesome. And Ray, what right now would you say the timeliness is for referrals? Is there a backlog? Are folks getting in with the specialist quickly, or what does that look like?
It depends entirely on what specialist it is. If you have the best insurance of Chattanooga, unless it's an absolute dire emergency, it'll take you 6 months to see a neurologist.
Yeah. Yeah.
And so we have, you know, some specialists, sometimes we get very, very quick turnaround. We're really designed to focus on emergent care, not urgent care.
Yes.
But sometimes we can get people in very, very quickly. But we face all the same problems that people with insurance face with a number of specialists with very, very tight turnaround or very long waiting periods.
No, and what you're saying is not unique in that regard. We have another group of clinic partners, and it's not that they don't have even access to specialty care, right? It's the wait that oftentimes folks can't wait 3 to 6 months to see a specialist, especially when you're working with underserved communities. That means they have to rely on public transportation, take time off of work. So having these services a couple clicks away for the provider is able to sort of mitigate that problem. Another thing that you touched on that I don't know if there would be some overlap here, with another partner, we're doing what we're calling a referral hygiene program. So before referrals are even sent out, they do go to our specialists to review and say, okay, hey, no, you can manage this person's care in-house, or no, absolutely, this person needs to see a specialist in person sooner than later. So there are ways that we can tailor and individualize our approach based on the needs of the groups.
Yeah, that's
One of the
really
things
That is wonderful. One of the questions, it's just a comment, but one of the things that strikes me is our issue is also with follow-up.
Yeah,
That we will move heaven and earth, and we will buy bus tickets. We will have someone call, but life is life. And when people don't show, they're right back in primary care. And so there are a group of people for whom we are either by choice or default managing a much broader spectrum. And I'm just thinking that this may be a way of really potentiating the skill set of our primary care teams to manage, just because the reality is, even when we do have access, there are a lot of other factors that play a role in engagement. And what's happening is, I don't know about other places, but we are watching particularly during the pandemic, it's been almost like a shutdown with our specialists, because they're less likely, I guess, because of revenue losses last year, to see our patients. So we're really struggling even in areas where we didn't 1 year ago.
No, absolutely. And you touched on something at the beginning of your comment about provider education. So our suite of services are designed to be complementary, that yes, you do have the one arm as the consults, but also through those educational sessions, you are giving the provider group just a better knowledge base that when they see a patient the following week that presents with similar conditions, they may not even need a consult, send out for a referral. They feel just better equipped to manage that patient's care themselves.
One of the things I think I could see from a project access or even any clinic perspective is the specialty areas where we kind of have a bit of a desert, even for those that are available for insured folks. So here in this particular area, it is really difficult, even if you have insurance, to get in with rheumatology or endocrinology, where if those patients could just have a specialist to review their records, we can fulfill their testing, their labs quite easily. It's really just having that specialist to review their information and make sure that the medication that they're on is appropriate, where primary care doesn't quite feel comfortable monitoring those things because they're not equipped to do so. That's where I could see a benefit for some of our patients in our primary care clinics, for a lot of those patients that, to Ray's point, I think we do a really good job of connecting patients with orthopedic or cardio or dermatology, but really the where we struggle is some of those other ones where there's a desert, even if you have insurance.
Yeah. I'm sorry, I didn't mean to cut you off. Go ahead.
No, go right ahead.
I was just going to say that what we do find, and I have these conversations several a day with different clinics across the country, is there are generally specialty areas, like I think you said it beautifully, there's a desert of sorts, right? So they might have really great access to a handful of specialties, but absolutely no help, no access in others. So that's not unique, just validating what you're saying there. And then secondly, although MAVEN's goal is to provide access, increase access to specialty care for uninsured people, when providers submit consults, there's no PHI, no insurance information exchange. So even if you have like a rare patient come in that has commercial insurance, good insurance at that, you can still absolutely send out a consult for that patient. So it's not only, you know, you don't have to think in mind like your patient panel, okay, these folks are uninsured, I can use MAVEN for them, but not for this group.
Jenny has a question. Jenny, jump back in.
I actually have 4 questions.
Okay,
Kept
she's
just
got
writing
4
them.
questions.
I can get my pen out, okay.
I'll ask them one at a time.
Okay.
Where do you recruit your specialists from?
So we recruit our specialists largely word of mouth from medical school alumni associations. Our founder actually, the MAVEN baby was born because she at the time was the president of the Harvard Medical School Alumni Association. So I actually have a colleague whose whole job is recruiting physician specialists, and they go through very rigorous credentialing process, background checks, reference checks. They have to maintain board certification and active licensure.
Okay. And are they all volunteers, or is there any compensation?
Nope, they are all completely volunteers. Actually, MAVEN stands for Medical Alumni Volunteer Expert Network. Say that 3 times fast.
Okay. And what region are y'all supporting now? Is it national, or you may have said this and I missed it at the beginning? I was kind of in and
I can
out.
go back here. So we are a relatively new nonprofit making our way across the country. So
Okay.
in the states that we're currently engaged in.
Okay.
And our volunteers are from everywhere, all over.
So assuming, since the point of this project is to serve the uninsured, which we very much appreciate, they have experience working with primary care doctors who may have limited tests and meds. So we, you know, and at least for Church Health, we have a huge Latino population. So if they don't have social security numbers, we have even more limited resources. So sometimes when we've worked with specialist volunteers, there is a learning curve or a hesitancy to give advice if it can't be best practice.
No, and I think that I'm really glad you brought that up, because I think that's actually one of our most unique differentiators, is that when all of our volunteers come on board, they understand that the provider groups that they're going to be working with are serving very resource limited groups. So they are not going to recommend a medication that's $500 per month out of pocket. They understand that there's language barriers, transportation barriers way beyond just immediate insurance.
Okay. And the last question is more just the normal liability documentation. So are there any guidelines around how we document this consult occurred and the advice given, since the primary care nurse practitioner provider may feel like they're practicing outside their scope if they don't document some way of how they came to that decision?
Yep, we ask that in the records, that the provider notes, I consulted a MAVEN project volunteer on this case.
Okay, that's all I had.
Okay, thanks,
You
Jenny.
sure?
Those were
I'm
great.
sure I'll come up with what y'all keep talking. I'll just keep
Yeah, well, one thing, Brooks, you know, piggybacking on what you were saying, you know, our State Department of Health has wisely, you know, turned to our Project Access group and said, wow, this is such an important service. We want to see it expanded statewide. But that can't happen quickly, because as I understand it, it's really relationship based. And so it takes a while. You know, there's a certain amount of it that they could do quickly, which they're doing. But we have a lot of other areas in the state. I mean, I just wonder about augmenting, which I'm not in the midst of what Project Access is doing directly with the Tennessee Department of Health, but I guess I'm advocating with you members that are to suggest possibly the state considering augmenting the work that you're doing now for some of these other areas and paying for it, because they do have that budget.
One question I'll have is kind of piggybacking on the other questions that were asked recently related to the logistics of the consult. So when a consult is scheduled, is there the requirement that the patient is present in office with a clinical team, or is it just facilitated? Is the scheduling of the appointment facilitated by a clinical team member and then the patient attends that on their own? How does that work?
Yep, great question. And I think you hopped on a few minutes late, so you probably didn't hear this, but we are not direct to patient. So actually the patient cannot be in the room. Even if they're still in the exam room and the provider steps out to send off the consult, the patient is not involved. It's provider to provider.
Okay, I did miss that, sorry.
And it is the provider who requests the consult. And you can see in the slide deck that Sarah and her team will send out when, so if let's say Dr. Khatri, she has a MAVEN account, she herself will log into her account on the platform and be able to send out her consults as she wishes, go back later on and look at all the consults she submitted in the past to review notes and so on. So to long-winded answer to your question is that the provider themselves initiates the consult.
Okay, thank you.
Of course.
So going back to the grant opportunity, we have up to 5 grants, but it's a quick turnaround. And you don't have to be in, Memphis. Memphis is a great location to participate because of the incidents. I don't know that we have, Ray, I don't know what the incidence is like in Chattanooga. I mean, I just don't know, but wherever there are high risk, wherever there are minority populations that are underserved, we have ground for you to submit the application. Where I would think even, Brooks, I'm thinking about you. Brooks is up in Appalachia. We have a whole lot of needle use. And that is, of course, one way that HIV can be transmitted.
We're in Johnson City in Washington County, and so we have actually an HIV Center of Excellence here with our medical school, East Tennessee State University.
So you would be, when Tim and I talked, it was like, well, and I was thinking about Jackson as well, which is kind of, an underserved area as well. But, they're just, you guys know, but she was very flexible in thinking is flexible in thinking with you about how you could apply given the population that you're serving. So I want to make it clear, it doesn't have to be just people of color. There are other people who are at real risk.
Is there a way, I'm sorry, is there a way that this can be paired with the project access programs throughout the state so that it can serve more clinics if it's just facilitated through project? I'm just thinking outside the box here.
Great idea.
If they're required to, since we all have kind of come to this same conclusion of, okay, we can't just let everybody just refer people to any specialist they want. We have to have rules around what you treat internally versus what you send out. And if this then gets layered into it, I'm wondering if that would be a way to serve more clinics by using the project access programs. What do y'all project access folks think about that? And that's probably not a short-term solution, but maybe more of a longer-term possibility.
Might be a short-term solution because there are 5 of them. There are 5 grant opportunities. And if we could chunk the whole state up, you guys have been working on chunking up the state. I don't know if it's a possibility in Timmy's world. Timmy, what do you think?
I think it absolutely is. And I'd actually written down a couple of notes and chicken scratch to follow up on this. And I think what we could even explore is maybe using this grant funding as a pilot of sorts, partnering up with 5 groups, getting started, seeing how the utilization is, the positive impact it has, then maybe going back to Project Access or whoever has the purse strings, if you will, and saying, hey, we have done this for 6, 12 months, whatever. This is the data so far. So clearly it's having impact. Fund more clinics, please.
Do you have a list of the specific demographic characteristics you're looking at for this grant specifically?
So in the application form that you will be linked to in the slide, if you click on here, we do ask like in the patient demographic section for you to break down race and ethnicity of your patient population, what percentage speaks English as a second language. And then there's a free text box at the bottom where we just ask you to include more qualitative information of lack of resources, need, why you think you'd be a good candidate for the services at large.
Thanks.
Yeah, and I am confident that, again, anyone within the charitable care network or FQHCs, you could probably make a good case of whether you're directly or indirectly impacted and could benefit from the grant funding.
Okay, so here's where I have to draw a sticky line. And so we love our FQ sisters. We adore them. We grew out of them. We partner closely with them, but they are not TCCN members. They're associate members because they receive federal dollars.
Mm-hmm.
And so this opportunity through TCCN isn't extended to our FQs, but you guys have money, so you could buy it.
Yeah.
And I'm not picking on you. I love you. And seriously, but it's come up in other grant opportunities. Our FQs, you know, we have to draw that line where it would, if there are 5, let me say this, if there are 4 who want to do it, and we can't find another member who's an organizational member, I would be fine with saying one of our associate members can have it. But if there are 5 organizational members, I feel like we have to stick with that first.
It seems to me that if somehow it can work for the project access orgs to have this, and then people, the TCCN clinic, maybe I'm oversimplifying it, but the TCCN clinics could then access the specialty network just by going through project access. I mean, theoretically, we could serve all TCCN clinics in the entire state. Right?
And FQs, because the project access, I mean, to that point, the project access teams serve both. And so that's a really nice, I mean, that's why I was thinking the state might want to jump in as well, because, you know, you hit everybody that is in the state provider network for safety net.
Mm-hmm.
And the systems for project access are more robust for all these kinds of things. They have data, you know, project access they're all on one system, as I understand it. They know who they're serving. They collect a lot of data. They, you know, they would be good partners or in the telecommunications facilitation business, and they could make that access for all of our members and all of our FQ buddies.
So with that said, in the meantime, while the charitable folks are filling out this application, I'm requesting an introduction to the project access folks so we can start these conversations.
Great. You have 3 of them on
right,
here.
I see Ray, Blair.
Ray, Brooks, and Clint.
Yeah.
Clint is the newest, and he's in Memphis. Brand new. Hey, Clint. And then we have, we're missing our friends from Knoxville.
Mm-hmm.
Who else are we missing? Why am I forgetting?
Nashville.
Oh, Nashville.
Rebecca.
Right, where I live. Oh, yeah, that.
So are you saying that that would be a separate application, Timmy, or because we can include them as TCCN members, but
They are.
Mm-hmm. I don't think so. I think, you know, given this opportunity and there's 5 slots, and if we want to go beyond that, that would be a separate, I wouldn't say separate application, but a separate conversation to expand beyond the this grant funding.
we would have to, I don't know enough about how project access works. Ray, you'll have to school me, but I mean, you wouldn't be getting the kind of fee for service reimbursement by consult, right? We would need some sort of funding from the state just to administer, you know, you're connecting the provider to the account,
Right.
then you're done. I mean, that's like super easy.
Yeah, it's easier than getting somebody without transportation and with poor literacy skills to find a clinic buried someplace in a hospital.
Yeah.
So, you know, we could have a separate conversation and talk about that. I think we just need to think about what would be involved in the coordination effort, but I'm sure we'd all be happy to talk about it.
Yeah, sounds great.
So it has to happen quickly. Will you all want to do that directly with Timmy? Or do you need TCCN to facilitate it in
I
any
don't
way?
think so. I think from the registration list, I have everyone's, at least Ray's email address, so we can coordinate.
Okay.
Yeah.
And I would think, like if, I'm assuming Church Health would be interested, I need to get this recording as quickly as possible to get it to my medical director. But I mean, we could still apply just to show our interest. And that way, if the project access concept kind of doesn't work out, or we just need more time to plan towards that, you would at least know what individual clinics, I mean, obviously Cherokee Health is interested. You would at least know if you have to go the more traditional route of just working directly with clinics, who's interested.
Jenny, I couldn't have said it better. Yes, I wouldn't recommend anyone who's interested does fill out this form, just so at least internally MAVEN knows who is interested and we can handle follow-up accordingly.
Yeah.
And then if you're going to send out the PowerPoint shortly so we can have the link to look at the application, and it's due next Wednesday. Okay.
And again,
Yeah.
and I said this earlier and I will say it again, most of the information you'll know off top of mind, but when asked for the patient demographics, insurance breakdown, it does not need to be to the precise decimal point. Guesstimates are completely fine. I would just encourage you in that text box at the end to share in your own words the needs, the uniqueness of your individual clinics.
So, hi, this is Perinda. I just want to clarify, and I absolutely get it, Sarah, in terms of the prioritization for our non-FQHC family. We all serve the same
We do.
community, and I do not want to take any resources that need to go, and are better utilized for our free and charitable clinics who are not FQHCs. But so should we apply just to show our interest, or should we not apply and then just have another conversation with Timmy in a different avenue, or wait for project access? What's the next best step forward for us in a way that's collaborative and supportive?
I would say, and Mary, please feel free to say if you disagree, I would say, please go ahead and apply to indicate your interest. And, if we want to prioritize the free and charitable clinics first, but we may only get 3 applicants. So there still may be a slot for you in this round, but if not, then we already have a lot of your preliminary information to hit the ground running for later conversation. When I say later, I just mean like next week kind of conversation separate from this grant.
I agree with that. Because I think this will give you access to a lot of organizations that you can be talking to. And as long as and thank you, Perinda, for being so gracious. When I said that very ungracious thing, but I think everybody should apply that's interested, and you, Timmy, will know who are organizational members. You can run through me, whatever you need, or Sarah, whatever you need for information. So.
And just a point of clarification, does this specific grant basically cover the cost, the $6,000 or $9,000 cost for 1 year to participate in the program?
Yes, it would be free of cost to the clinics for 1 year. And then, as I outlined here, just then be as part of the MAVEN family, you will have access to our development staff at the end of that year if you want to stay on as a partner to how we can secure funding on an ongoing basis, whether we loop you in to what's established with project access by then or something completely separate.
And again, I think that this Tennessee Department of Health will be interested in supporting this as funds are available. This is very much aligned with their goals.
Great.
So you guys can see why I said, don't talk to me, talk to my members right away.
Yeah, I'm interested. Timmy, Ray, if you all coordinate a time to talk, I'm happy to be on that as well.
Yeah, absolutely. I will send an email to both of you by end of day today so we can at least start looking at calendars and finding some time, if not the end of this week next. And
Other
truly,
people? Anybody else have questions? Jump in here. Don't be shy.
and when you all receive the slides, my contact information is right here. So if you think of a question, a comment, please feel free to shoot me an email, give me a call, and we can keep the conversation going.
Yeah, and Sarah's helping me by sending the slides directly, actually to all the members, because people can't always participate. And then it takes a minute for this to download and for it to be something that we can post to the website. But the slides are great. They're really helpful.
Great, great. And all right, well, that's all I have. This is a very robust, good conversation, and I really am looking forward to working with all of you in some capacity.
Thank you so much, Timmy. This
Thank
is
you.
extraordinary.
Yeah,
Thank
this
you.
is a great opportunity. Thank you.
All right, well, I will talk to you all soon. Thank you
Great.
again.